Hello, everybody. I hope you can hear me and see me. Welcome to Fund the Fellow. Tonight, we're going to talk about the challenges that we face when making the diagnosis of Parkinson's, both on the medical side and as well as the patient side. So we definitely want to hear from you. We'll definitely be looking out for your questions. But, thank you again for taking this time this evening to learn a little bit more about Parkinson's and learn a little bit more about our program. Fund the Fellow is such a special program, very near and dear to my heart, because we're able to take young neurologists who just finished their residency training in neurology, and we're able to make them specialists in movement disorders. And these are the individuals that are going to learn how to take care of Parkinson's patients, learn how to use all the latest and greatest in the medications and the different technologies that we have, in able to give our patients a better quality of life. And that's what it is all about. And, because of this program, we've been able to touch the lives of thousands and thousands of patients and families and caregivers taking care of patients who have individuals with different movement disorders, Parkinson's disease, Lewy body disease, etc. So this is a very, very important program because the funding isn't available out there. So the federal government doesn't fund a specialist to be able to be trained in how to take care of Parkinson's disease. One of the things I've learned during this pandemic is how vulnerable our patients are when they go to the hospital, especially under these pandemic conditions, if they don't have a family member there to advocate for them. And I've seen time and time again, no good access to the medications that we're currently using for our Parkinson's patients, and patients being given the wrong or no medicine whatsoever while they're in the hospital during the pandemic. So definitely educating physicians on how to treat individuals with Parkinson's disease and related disorders is extremely important. And I want to thank the Fund the Fellow Foundation and family that really has funded so many neurologists to become movement disorder specialists. It's been very important, especially since we have about 1 to 1.5 million individuals with Parkinson's disease, probably the same amount with Lewy body disease. And as our population continues to grow, that number is going to continue to increase. So we really need to keep teaching our neurologists how to take care of these important disorders and make a difference in the quality of life of individuals with Parkinson's disease and individuals who are taking care of these patients, and it makes a difference in the family. So thank you again for joining us. I want to thank Janice Buchanan and Rick Shenna. So they really were the creators of this program, and they really have touched the lives of many, many individuals. So from the bottom of my heart, I thank them for really being the creators of this program. And a big warm welcome and thank you also to the development program at Georgetown University Medical Center. Again, a great partner in education and in teaching the next generation. And not only have we taught great doctors on becoming movement disorder specialists, but they've become in very important humanitarians and excellent researchers as well. And two products of this program, the Fund the Fellow program, are going to be here with me tonight. The first one is Dr. Elizabeth Mundell. So she is a product of the Fund the Fellow program. And not only is she a product of the program, she's also my colleague now. So we'll have Dr. Mundell with us today in the panel. And another excellent product of the program as well is Dr. Yasar Torres-Yaghi. So Dr. Torres-Yaghi has also been very instrumental now educating our fellows as well and doing research. So welcome both Dr. Torres-Yaghi and Dr. Elizabeth Mundell. Just going to wait for a few seconds here for Dr. Mundell to, there she goes, there she appears. So welcome both, and as products of this Fund the Fellow program, and now being my colleagues. I can't be, I'm so proud to have you tonight in today's discussion. So let's get to it. We have a lot of questions. So let's first get to how difficult sometimes it is to make that diagnosis. So Dr. Mundell, why do you think it's so hard to make the diagnosis of Parkinson's disease? We see time and time again in the general community that there's always a question: is this Parkinson's? Is it something else? Or maybe I just have a pinched nerve. Why do you think it's so difficult, just in your clinical experience and working with patients and making the diagnosis? Why do you think it's so difficult to make that diagnosis sometimes?
That's a great question to lead us off. Thank you so much for having me. Yeah, I'll say, it's true that we see patients all the time who have been to one specialist, another specialist, before they ever get to even consideration of a diagnosis of Parkinson's. And that's because it's such a heterogeneous disorder. I mean, we see presenting symptoms vary so much. People assume you have to have tremor in order to have a diagnosis of Parkinson's, which is definitely not always the case. And so I think, certainly the Fund to Fellow program is important because we're training people to know more about Parkinson's and look for those warning signs. But as we'll talk about, Parkinson's has a lot of both motor and non-motor symptoms that can present. And so, a lot of different symptoms bring patients to the doctor for the first time. And when patients don't have that classic tremor that people think about so often, they're often, bounced from one doctor to another and sometimes more resistant to accepting the fact that it might be kind of one unifying diagnosis that puts all of their symptoms together.
So you bring up a great point, that it is a difficult diagnosis to make, and it is very heterogeneous. So there is a big umbrella term of Parkinson's disease, and there's really many disorders that definitely fall under this. I always like to tell a little story about Parkinson's disease. When we were getting, and this happened to me probably over 20 years ago. But when we were just learning about the genetics, and we'll touch upon that a little bit later, I was teaching this group about the genetics about Parkinson's and how different patient from patient is and what's different. This wise neurologist looked at me and he goes, Dr. Pagan, when I tell my patients about Parkinson's, I talk about Neapolitan ice cream. And I'm like, Neapolitan ice cream? What does that have to do with Parkinson's? That's what I'm thinking to myself. And he goes, yes. He goes, no matter how you scoop it, you're going to call it Neapolitan ice cream. But when you take a look at each individual bowl, some get a lot of vanilla, some get a little bit of chocolate, and then there's always that one that gets all the strawberry nobody wants, So that's how variable it could be. So it's there's a lot of variability. So I think Dr. Mundell brings an excellent point about how heterogeneous a diagnosis is. And we do have a term in Parkinson's in that we see one Parkinson's patient, we see one Parkinson's patient. And it's very important for us to make that diagnosis and individualize the therapies for that individual. So Dr. Torres-Yaghi, what are some of the motor and non-motor symptoms that lead to the diagnosis? And, why is it that sometimes you don't realize that you're even having this symptom? So can you explain to us go a little bit more in depth in those motor and non-motor symptoms that we see?
Another great question. Thank you. Whenever we talk about the diagnosis of Parkinson's disease, we tend to focus a lot of the time based on the UK Brain Bank criteria, which is a strictly motor criteria. We talk about tremors, rigidity, slowness of movement or bradykinesia, impairment of gait. But the ones that are hard to detect in many cases, and without the right training, without the right fellowship, without the right open-mindedness and perseverance, a clinician might miss these things because these things can be non-specific. We call them non-specific. Something like fatigue or lightheadedness can be seen in multiple different disorders. So it's really a comprehensive view that we need to look at. aside from the motor symptoms, the non-motor symptoms can vary. We tend to learn in our fellowship that aside from those tremors, rigidity, and slowness of movement, the symptoms of non-motor symptoms are very much based on the different organ systems that are also affected. The nervous system is also part of all organs. And so you might experience non-motor symptoms such as psychological changes like depression, anxiety. You might feel fatigue. One of the biggest things is sleep. One of the most important questions we ask our fellows is, let's not forget to make sure that we don't focus on sleep. We have to make sure that we're asking about, is it easy to fall asleep? Is it easy to stay asleep? The most common sleep disorder is called sleep fragmentation. It's just hard to stay asleep. Dr. Pagan always used to say, he used to ask, is it hard to stay asleep? Do you feel like you get uncomfortable? It's hard to turn in bed. You might have stiffness that you feel in the middle of the night. Those sorts of things we screen for almost at every visit. And you can even make your own visit just about those non-motor symptoms. Things like REM behavioral sleep disorder or acting out one's dreams. When we're supposed to be dreaming, we're supposed to be paralyzed, right? We're not supposed to act out our dreams, but in Parkinson's disease, we sometimes can experience acting out of one's dreams. What about something that would probably seem like a completely different disorder, like needing to urinate a lot at night? That's called Nocturian. One might go to a urologist and they might get a bladder evaluation or a prostate exam. And they might say, well, my prostate's enlarged. That's why I'm urinating a lot at night. That could be a non-motor symptom of Parkinson's disease. And there are so many more that we focus on. Things like lightheadedness, that's called neurogenic orthostatic hypotension, where our blood pressure might drop when we stand. And we can't forget all of the other aspects of non-motor symptoms. Pain, we're taught in our fellowship, is one of the most underdetected non-motor symptoms of Parkinson's disease. And so we have to kind of always put it all together, and we use that analysis not only to think about how we can help, but since this conversation is about diagnosis, it also helps us diagnose what other features we're dealing with. Are we just dealing with the motor symptoms, or are there other features? The one important one that I didn't mention was constipation. So part of our training, when you do a movement disorders fellowship, Dr. Pagan always tells you, and I've seen Dr. Mundell in action doing all this, putting on your different doctor hat. Dr. Pagan says, put on your psychiatry hat when you have to, put on your internal medicine hat when you have to. You have to put on your gastroenterology hat a lot. And I remember, there are certain weeks, Dr. Mundell, Dr. Pagan, and I would be in clinic, and we would feel like we're a gastroenterologist because we would be talking about constipation, decreased motility of the gut, and among other things. So if you don't think about the condition holistically, it's hard to find that right diagnosis. And if you're not screening for the right problems, you're not going to find the therapeutic solution to them. And in 2021, there's a lot of things that we can do to help on all those fronts.
So Dr. Torres-Yaghi brought up a lot of great points there, especially the non-motor symptoms, things that can present before we see those motor symptoms. So the constipation, the sleep difficulties, or the REM behavioral sleep disorder, anxiety, depression, fatigue, all of these signs and symptoms can be there well before the motor symptoms ever are seen, and before we ever make the diagnosis of Parkinson's based on the motor symptoms. Dr. Torres-Yaghi also brought about this term, United Kingdom Brain Bank criteria. Dr. Mundell, can you explain to all of our guests tonight, what is the United Kingdom Brain Bank criteria, and how do we make the diagnosis of Parkinson's? So here we just heard of all these different types of symptoms that patients can have, the non-motor symptoms. You can review the motor symptoms that are necessary for the diagnosis, but how do you make the diagnosis?
So really, Parkinson's remains a clinical diagnosis, which is one of the reasons why so many of us are fascinated by Parkinson's and love taking care of Parkinson's patients. We don't rely on a particular blood test or a particular imaging study necessarily. We really examine the patient and make a clinical diagnosis that way. So when we talk about specific criteria, we're talking about looking for cardinal features of Parkinson's, ruling out other conditions that may mimic Parkinson's, and ultimately when it comes to Parkinson's disease, trialing medication to see a response to medication. And I think there's a lot of details in the criteria, but that really gets to the heart of what we're doing when we're looking at a patient to decide, is this Parkinson's disease versus some other condition that may still fall under the umbrella of Parkinsonism, but not necessarily be Parkinson's disease.
So how would you describe to somebody who would say, what is Parkinsonism and what is Parkinson's disease? Dr. Mundell, just to clarify that particular term, because that's actually a very common question that we get in our exam, because when we first meet a patient, we may use the term Parkinsonism. There's Parkinsonian signs, or there's Parkinsonism. So what's Parkinson's disease?
So the way I usually describe it is that Parkinsonism is sort of an umbrella term that we use that encompasses lots of different reasons why, or lots of different reasons that explain the motor symptoms or the constellation of clinical symptoms we see on the exam. And there are many different reasons why you can have Parkinsonism, the most common of which is Parkinson's disease. But there are other things that can mimic Parkinson's disease that we want to rule out. So for example, if you've had strokes in certain parts of the brain, that can make someone look Parkinsonian without a diagnosis of Parkinson's disease. If they've been on medications in the past that can block dopamine, they can look Parkinsonian or have Parkinsonism without having Parkinson's disease. And then if there are certain what we would call more atypical features, which I'm sure we'll talk more about, but things that come up a little bit earlier, for example, significant cognitive impairment really early in the presentation, if they're having hallucinations early in the presentation, if they're having a lot of falls, a lot of dizziness and lightheadedness, these are all things that may make us think, okay, this is some Parkinsonism, but not straightforward Parkinson's disease. And sometimes we can't necessarily figure that all out in one visit, and it takes a little bit of time to kind of sort out all of the specifics of what's causing the Parkinsonism.
Yeah, and that's why in the United Kingdom brain bank criteria for Parkinson's disease, a movement disorder neurologist or neurologist sometimes needs up to 5 years really to know the patient, because it's not always right to go off the bat and start with the big gun, medicine like carbidopa, levodopa to get the dopamine levels up. But it's the response of the medications that really ultimately tell us that are we dealing with Parkinson's disease versus Parkinsonism or any other disorder. One of the things that we tell our patients that the first time we meet them, yes, they may have some non-motor symptoms, and there may be slowness in movement, the bradykinesia, which has to be present to make the diagnosis of Parkinson's disease. There could be rigidity or stiffness, and there may or may not be a tremor. If we call them Parkinson's disease at that first visit, we have a chance of being right 85%. But we also have a 15% chance that it may be another disorder, as Dr. Mundell went very thoroughly over all the different types of disorders that fall under the umbrella term Parkinsonism or Parkinsonian syndrome. So really, sometimes it does take a little bit of time to really make sure there aren't any atypical features. And once we begin the right medications, that there is a response and an improvement, a significant improvement in those motor symptoms, that we ultimately make that diagnosis of Parkinson's disease. Dr. Torres-Yaghi, another question that I think we get from a lot of our patients, okay, it's a clinical diagnosis, but how can you be sure that I have a dopamine deficiency? Or is there a test that you can measure to test for a dopamine deficiency? How do you respond to that? Because that's a very common question that we get.
I think it's a question that we do answer quite regularly in clinic, especially when we're making a new diagnosis. Dr. Mundell mentioned, that when we make a diagnosis, especially if there's no tremor, patients tend to say, how come I have Parkinson's disease? I don't have a tremor. And we tend to tell them, unfortunately, you don't always have to have a tremor to diagnose Parkinson's disease. If you have slowness of movement with stiffness, that could be enough to go down the diagnostic path, trying to understand whether or not you have Parkinson's disease. So we use multiple features of our training. So there are things called biomarkers. We have clinical biomarkers, which are exam tools that we use. We're trained throughout our fellowship to learn how to create in our minds a standardized approach to examining a patient to try and bring out Parkinsonian features. So once we have a suspicion based on our clinical examination, we then analyze the non-motor symptoms. If we do see that there are people that have non-motor symptoms, that also helps raise that diagnostic certainty. I tell my wife this all the time. I say, I'm a neurologist. We live in a gray zone all the time. There's multiple factors always that we have to weigh the risk benefits, understand the whole picture. It's very different. My wife's a dermatologist. Sometimes it's more binary. In our world, it's very dynamic. We have to understand a lot. And so sometimes we have to do an MRI, like Dr. Mundell said, to make sure that we're not dealing with enlarged ventricles in the brain that can cause what looks like a Parkinson's disease, or big strokes, or other features that in the brain that the MRI can evaluate for. The other very important tool that we have at our disposal at big academic centers like Georgetown, they don't have it everywhere, but a nuclear medicine scan that can look at the dopamine receptors in the brain, in the part of the brain that affects movement, the basal ganglia. We do the nuclear medicine scan called the dopamine active transporter scan, or the DAT scan. And when we do that, that helps. Again, if it's a positive scan, that means that we do see a dopamine deficiency within that scan. Now, through the fellowship, Dr. Mundell's worked diligently within with the translational neurotherapeutics program, with our Lewy body disease and Parkinson's disease clinical trials, everything that we're trained for to become an attending. A lot of that, the tests, like the lumbar punctures, have been done by the fellows. I remember when I was a fellow in 2015, I was doing the lumbar punctures for the phase 1 study. And then Dr. Mundell got to do the lumbar punctures later on when she was a fellow. But we are working on at Georgetown, through Dr. Pagan and Dr. Musa's research, a way to actually analyze the cerebrospinal fluid to see if we can determine whether or not there are biomarkers that help us monitor disease progression. That's something in research that we're looking at. And we go and we're presenting at all of the meetings this year, last year, and the years coming. And hopefully we at Georgetown, through the fellowship, will also be able to determine some sort of plan of action to find other ways of determining whether or not someone might have Parkinson's disease.
So we'll come back to that, to those biomarkers in a little bit, because that's very important in research. But Dr. Mundell, so Dr. Torres-Yaghi brought up a point about the DAT scan, so the dopamine active transport scan, that can tell us about ultimately the dopamine neuronal concentration in patients who we think have a dopamine deficiency. So how about that? So do you order a DAT scan on everybody? Is that how you make the diagnosis, or what kind of information does a DAT scan? How does it help you? Can you give us some examples how it can help you? But ultimately, what is it that you do?
So many patients come in and they want some sort of imaging study or something to prove that they have the dopamine deficiency. But you're exactly right. What we've talked about, that Parkinson's is a clinical diagnosis, and we don't need the DAT scan to make a diagnosis. In fact, sometimes the DAT scan can be sort of equivocal or not necessarily positive in someone that we have a high clinical suspicion could have Parkinson's. And in those cases, we still would choose to treat a patient and see how they respond to medication, because often those studies over time will become positive in patients that we have a high clinical suspicion for Parkinson's. So we use the DAT scan to help us, especially in cases where, like I mentioned before, if a patient has been on medication in the past that may sort of block dopamine or mimic a Parkinsonian syndrome. If they've had essential tremor for a long time, sometimes it can be helpful to distinguish an essential tremor from Parkinson's. But in general, Parkinson's is a clinical diagnosis, and we don't need the DAT scan. Sometimes I've used it to help convince a patient when they need some sort of test to kind of prove it. But it can be helpful in those situations. But like I said, even if the DAT scan comes back as equivocal, we're not convincing for a dopamine deficiency on that scan, but we still have a high clinical suspicion for Parkinson's. We're still trained and we learn that we should treat the patient because often they will still see that robust response to levodopa, and we can still improve the quality of life very much.
Yeah, absolutely. I think you bring some excellent points on the DAT scan in that, definitely for some of the more difficult patients that may have had an exposure to a dopamine receptor blocking agent, that's the right time to use it. The ETPD patients, because 20% of patients who have essential tremor may go on to develop Parkinson's, so it kind of helps rule it in or rule it out for some of our patients. So that could be extremely beneficial there. And again, I think you're 100% right. Sometimes it's the tool that can help us accept the diagnosis and then ultimately accept taking medication to help improve those symptoms in the patient. So, and we do have challenges in the way some of the quantification is done today. We disagree with some of the interpretations of the DAT scan. And again, the nuclear medicine doctors lack one thing. They lack evaluating the patient in front of them. Together with our evaluation and what we see in the DAT scan is much more valuable than a numerical number that's been normalized, and it's still relatively new technology. Hopefully we'll see that improve over the years. But we definitely, as neurologists, have an advantage that nuclear medicine doctors don't have is that we did a physical exam, and that's a big difference. So that is a tool that we have, and it's not something that has to be done for everybody, but it is something that we can use when it's appropriate to be able to use for our patients. And Dr. Torres-Yaghi, now, Dr. Mundell brought some really good points when she was bringing up other syndromes that look like Parkinson's. A very common syndrome that gets confused for Parkinson's and sometimes Alzheimer's disease is Lewy body disease. Can you explain what is the difference between Lewy body disease and Parkinson's, and how do we make the diagnosis of Lewy body disease?
It's an important question to answer, and I'm really happy to be able to answer it in this forum, because the Funda Fellow program, what it did for us since I became a fellow, Dr. Pagan and Dr. Musa had started working a lot on cognitive changes within Parkinson's disease and understanding more about that. We actually developed a Parkinsonism and dementia clinic, and so every fellow was now trained since I started as a fellow. We are trained through the fellowship to become not just Parkinson's disease specialists, but also memory disorder specialists, kind of a hybrid-like fellowship. It's very unique. I haven't seen it anywhere else in all the other academic centers. And what it allows us to do is really not neglect the cognitive aspects to a Parkinsonism. And Lewy body disease is, and we're taught, is on the spectrum with Parkinson's disease. But there are features that are more pronounced in Lewy body disease. Cognitive impairment or memory dysfunction, hallucinations that can be there and can come and go, delusions, which are fixed ideas like paranoia can happen sometimes. And we see features of all of those things combined in the setting of acting out of one's dreams, among other features. And When we put it all together, we might have the diagnosis of Lewy body disease. Now, what we tend to tell people is whenever we have that diagnosis, doesn't mean, that it's still not a treatable condition. It is a treatable condition in many ways. What tends to happen is with a diagnosis such as Lewy body disease, if we learn about it and read about it, a lot of the information out there is very much outdated and it's not current. And what they used to do is take very severe cases of Parkinsonism and Lewy body disease and say, well, if we have all those features together, then we most likely have Lewy body disease as a diagnosis. But in reality, because we believe that Parkinson's disease and Lewy body disease are on a spectrum, if we have a symptom such as memory loss or dementia, we treat it with Alzheimer's disease medicines. And the Alzheimer's disease medicines actually work in Parkinson's disease, cognitive impairment, and Lewy body disease. But through the fellowship, we've been able to create a program for our patients so that we really do an in-depth analysis with a movement disorders lens. So we're not only examining the patient's movements, but we're also evaluating their cognition. We evaluate them with a Montreal Cognitive Assessment. We evaluate them to make sure that they don't have depression or anxiety using a questionnaire. And we also make sure that they're not experiencing any of those features of psychosis, like visual hallucinations or paranoia that sometimes happens, more likely in Lewy body disease than Parkinson's disease.
So it is a unique program that our fellows are actually trained in not only movement disorders, but also memory disorders as well. And about half of our patients with Parkinson's are ultimately going to have some cognitive dysfunction. So I think it definitely goes hand in hand with the fellowship training and learning how to use these medications as well, because we do see other movement disorder specialists from other areas. Oh, you have a memory disorder. We don't treat that. We're just treating the motor disorder. But we definitely follow the cura personalis. We treat the whole person at Georgetown, and that's what makes Georgetown different and unique. So I think this is one of the strengths of our program, in that we are working together with the memory disorders program, and in the future we'll be hopefully working even more together. That's our plan. Well, Dr. Mundell, you brought up some other very interesting points when you were talking about the umbrella term of Parkinsonism or Parkinsonian syndromes. Can you now tell us about some of the atypical features and how long it takes to make those diagnoses of atypical Parkinson's disorders? And what are some of those atypical Parkinson's disorders? We hear terms always being thrown out, atypical Parkinson's or PSP, CBD, MSA. What are those? Can you explain what those are?
Sure. I'll give sort of a brief overview, and then if we have questions, we can delve in more about those. But we talked a little bit about Lewy body disease, and certainly that's under the umbrella of atypical Parkinsonisms or atypical Parkinsonian disorders. Some of the other ones that we come across, there's one called multi-system atrophy. And typically when we see a lot of symptoms of autonomic dysfunction, a lot of lightheadedness and blood pressure changes, people stand up and they're passing out very early on, that may clue us in that we're dealing with something called multi-system atrophy. And there are several variations within that, but certainly early autonomic changes and prominent autonomic changes are some features that we look for with what we would term MSA or multi-system atrophy. Another atypical Parkinsonism is CBD or cortical basilar degeneration. And typically that is a very asymmetric disorder. A lot of times we see a lot of muscle stiffness or tightness on one side of the body and maybe difficulty using that particular side of the body, a term we would call sort of apraxia. On one side of the body, and that may clue us into a CBD. Another atypical Parkinsonism, we talked about MSA, we talked about CBD, we need to talk about PSP, which is progressive supranuclear palsy. And so someone who has a lot of early falls, or difficulty with their eye movements may clue us into having a diagnosis of PSP. And like we talked about, a lot of these disorders, take some time to sort of sort out. We see someone in our clinic, a lot of people will come in with falls or some lightheadedness, but it's sort of how prominent those are and the progression over time that we're looking at. And so the reason that it matters is because, in Parkinson's, we expect that big, robust response to levodopa. And we certainly treat all of the atypical Parkinsonisms with medication and can improve the quality of life dramatically. But we may not see that same robust response to medication that we would with straightforward Parkinson's disease.
And I think that's a very important point. And very nice job identifying the different atypical Parkinsonisms. And we still use that medicine, but in the atypical disorders, it's a more modest benefit than the market benefit that we see in Parkinson's disease. And again, it could be very variable how in the length of time for us to make that diagnosis. And Dr. Mundell mentioned that the progression can be more pronounced or quicker in some of the atypical disorders than true idiopathic Parkinson's disease. Since you brought up biomarkers, Dr. Torres-Yaghi, what are some of the differences between, let's say, CBD and PSP and some of the other Parkinson's and other Parkinson's related disorders? What are the biomarkers, or what are the specific differences in the proteins that accumulate?
Great. So I still remember when I was a fellow and Dr. Pagan, whenever we're thinking about creating a diagnosis, there's something that we're trained to do. It's called, we have to devise what's called a differential diagnosis. And that's kind of what we're talking about right now. If we see something that looks like Parkinson's, let's make sure that we're dealing with what we think we're dealing with. And so we have to also make sure that we're identifying or ruling out all the other disorders that Dr. Mundell mentioned. That's called a differential diagnosis. And what helps us think about it and categorize it in our brain is to think, as an umbrella term, we say Parkinsonism, but there's also an upstream cause to everything. And that's due to a protein accumulation. All of these disorders are neurodegenerative disorders. Alzheimer's disease is a neurodegenerative disorder, and it's due to protein accumulation. ALS is also a protein accumulation disorder. Now, of course, all of them look very different, and even within each diagnosis, like we said, one Parkinson's patient might vary very much in terms of symptoms compared to another. But the way we determine and classify each disorder is based on the protein that accumulates in a more pronounced way. And in Parkinson's disease, we think about it as an alpha-synucleinopathy. And alpha-synuclein is the protein that accumulates within the neurons and provides a type of environment where it makes it hard for those neurons to function. Those neurons can no longer release the chemicals they need to release. In Parkinson's case, because the alpha-synuclein accumulates, we can't release dopamine, and it leads to the deficiency in dopamine. Another alpha-synuclein disorder is Lewy body disease. Lewy body disease, as we said, clinically, we think about it on the same spectrum as Parkinson's disease. And then we think about multisystem atrophy. That also is an alpha-synuclein disorder. In multisystem atrophy, you might also experience, in terms of an accumulation of protein in the brain, you might also have it around the nervous system that surrounds the blood vessels. And that's why you might have a difference in blood pressure fluctuations in multisystem atrophy. Now, tau is another protein that accumulates. And the other neurodegenerative diseases might be due to an accumulation of that protein. Alzheimer's disease, progressive supernuclear palsy, and CBD, the disease, not the new compound that everyone's asking about, CBD oil. CBD, the diagnosis, is also a disorder that has to do with an accumulation of tau. And if we think about it that way, it doesn't only help us categorize the disorders, it also helps us figure out how we're going to target these disorders therapeutically. Because now, when we think about how we're going to take care of these disorders for the long term using therapeutic interventions or in clinical research, we think about how are we going to target these proteins, or what sort of new compounds are we going to use to target the proteins that accumulate. If we can reduce the amount of proteins within the neurons, it'll help us overall figure out how to reduce the symptoms downstream.
Okay, so I think so you bring up a lot of important points in that answer, but definitely we have our alpha-synucleinopathies, which include Parkinson's disease, Lewy body disease, pure autonomic failure. Those are the big ones. We also think about the tau proteins, where we see tauopathies with CBD and PSP. But tau is very important in frontotemporal dementia, also important in Alzheimer's, as you mentioned, as well, and ALS. So there's so much interplay between or among these disorders, and we're continuing to learn so much, and there's a lot of cross reactivity there. So there's a lot more gray than just being black and white. So and I think that's having that fundamental understanding is extremely important, and it won't be surprising when we ultimately learn that a drug that could potentially be helpful in Alzheimer's also treats Parkinson's, and that's where the future is headed, and that's where a lot of our research is headed as well. So Dr. Mundell, one of the questions that I got is somebody is a biological child of a parent with Parkinson's. What are the chances that they're going to get Parkinson's disease, or should they just start taking levodopa now to prevent the disease? How would you respond to a child of a person with Parkinson's?
I think that's a really fantastic question. I think we get a lot of questions about the genetics of Parkinson's, and the truth is we're learning a lot about the genetics of Parkinson's. I don't think we have all the answers right now. There are certain genetic markers that we know exist and for Parkinson's right now, but I'm sure there are many, many more that just haven't been discovered yet, that hopefully in the future we'll have sort of targeted therapy depending on what genetic marker people have, similarly to the way we treat cancers. But the answer to, I guess right now, if there's a child of a patient who's asking about whether or not they should take levodopa prophylactically, no, the answer is no. So there would be no reason to start levodopa. But we're learning a lot about it, and I think as genetic testing is more routine and we know more about genetic markers, there will definitely be a role for sort of more genetic testing down the line. And there are clinical trials going on now for people who have specific genetic markers of Parkinson's to see if there are potential therapies that would be specific for their genetic markers. So a lot of the genetic questions are being studied right now, and it's a really exciting time because we may be able to change the way we target specific patients with specific genetic markers for Parkinson's down the road pretty soon.
You bring up an excellent point, Dr. Mundell. You're absolutely right that we are learning a lot about specific therapies potentially with GBA and LRRK2 gene genetic mutations. If you are a patient or know somebody who is a patient with Parkinson's who wants to be involved in some genetic studies with we are a Parkinson's Foundation Center of Excellence, and with the Parkinson's Foundation, the International Foundation, there is research that you can be part of if you wanted to be part of. It's called the PD Generation Study. So PD Generation, the gene eration, actually really a big on the website, and one could sign up for that if they wanted to be part of it. So always like to let you know about studies that I think will lead to hopefully better understanding of Parkinson's, and maybe ultimately in the future, if you have a specific type of Parkinson's, which class of medicine may work better for you. And ultimately, hopefully we'll find specific treatments for some of those genetic forms. But Dr. Mundell is absolutely correct. If you have a family member with Parkinson's, you don't really want to start taking these medicines, especially if you're asymptomatic. And a biological child in general, if you just take a look at all the genetics, there are some forms of Parkinson's that do follow autosomal dominant or autosomal recessive, meaning 50% of the offspring or 25% of the offspring. But with some idiopathic, we don't even know certain genes, and everybody has about a 2% chance of having Parkinson's disease. And if you have a parent who has Parkinson's, you've increased your 2% to 3%. So in my math, that means you have a 97% chance that you may not get Parkinson's. So it's better not to start taking the medications at that point. So we did bring up gastrointestinal issues, and Dr. Torres-Yaghi brought that issue up about the gastrointestinal system. Since he already talked a lot about biomarkers, what do you tell patients, with the constipation, Dr. Mundell, about why is the gut involved? What have we learned about constipation and Parkinson's?
Yeah, it's interesting. There are a lot of theories that Parkinson's may actually originate in the gut, and that the gut is one of the first centers that's involved in Parkinson's, which is why a lot of times when patients come in and we screen and ask for all of these non-motor symptoms, they say, "Oh yeah, I've had constipation for years and years and years and not thought too much about it." But definitely we think that the gut is one of the first systems that's involved in Parkinson's. And it's important to treat constipation and treat the symptoms in the gut for many reasons, but one of which is that it helps to absorb the medication that we're giving for Parkinson's when we rely on it, sort of an active working GI system. So it's important to treat that constipation. I know we're doing a lot of research in that regard also at Georgetown, to try to come up with new compounds to help treat that constipation in Parkinson's, which can be quite severe in some patients.
Yeah, so that same molecule, alpha-synuclein, is what it can affect the dopamine and serotonin cells of the gastrointestinal system. And again, a lot of theories thinking that's where it begins. And Dr. Mundell is correct that we have research, with compounds that hopefully remove the alpha-synuclein and restore the gastrointestinal motility. And we have a current study called the CARMET study looking at constipation. And as being a primary investigator in that trial, it's actually pretty exciting because it looks like the people who do get improvement with constipation, their Parkinson's symptoms definitely are better. And as Dr. Mundell said, if you can get the gut moving, then the medicines can get to the right place, and then medicines can be more effective. But it's quite a difference from a person having one bowel movement a week to a bowel movement daily, and all the different aspects where it could be improvement. In the phase 1 study, we saw a lot of encouraging signs, and now we're in a multi-center clinical trial. And actually, this was discovered. It's a molecule called it's called Interin, but it's a squalamine. It's a bile salt from a dogfish shark. It was discovered by Dr. Michael Zaslav, who was a transplant surgeon at Georgetown, and he's gone on to continue to work on this, and we're happy to help him in his endeavors. I want to remind everybody who's joining us today to go ahead and ask questions to us. Hopefully, some of the discussions that we've been having together here with Dr. Torres-Yaghi and Dr. Mundell has maybe led to some questions about maybe how their diagnosis was made, or some of the difficulties, or anything else. We'd be happy to answer the question. One of the questions that I have, and I may need a little bit of a clarification, but maybe either Dr. Torres-Yaghi or Dr. Mundell can answer this question. The first question that I have is, can Parkinson's disease cause abnormal blood values? So I'm not sure. I may be missing exactly what blood values, but I'm not aware of any blood values abnormalities specific to Parkinson's disease itself. I'll hand it over to my two other experts. Do you have any input?
No, I think to answer the question, we don't tend to anticipate any abnormal blood values in in Parkinson's disease. We always do tend to check for lab changes in the blood. Sometimes we'll check for B12, a B12 deficiency, because people that might be deficient in B12 may have some neurologic symptoms. We tend to do that more with cognitive impairment. We'll check a thyroid function test and a folic acid level sometimes, among other things when we run into cognitive impairment. But for Parkinson's disease, we don't tend to check any labs, blood labs with diagnosis.
I think you definitely bring up some very important points there, Dr. Torres-Yaghi. Definitely when we do a cognitive evaluation, we do check for B12 deficiency, thyroid function tests, or any other irreversible causes that can cause memory impairment. Parkinson's in general, over time, we could see a lot of vitamin B12 and B6 deficiency. This could be problems with absorption of these difficult vitamins or fighting off with the medications that we're using. Our medicines definitely have to be monitored. So we do ask our primary care physicians to test routine liver function tests and CBC over the years, just on maintenance wellness exams on a yearly exam. We do notice a little bit of B12, besides B12 deficiency, iron deficiency sometimes, and anemia in our patients. And I don't know the direct interaction there, that we do see that quite a bit, but this is long-standing disease, and this could be an anemia of chronic disease, or there could be some interaction with levodopa. A lot of the levodopa labeling does talk a lot about iron salts and iron deficiency and anemia. And to be 100% honest, this is still very unclear in the literature, but it is something that we keep an eye on. The other, I got a great question from one of our panel, or one of our individuals who was watching this presentation. Polypharmacy, Dr. Mundell. We practice polypharmacy. What would your answer be to somebody? Why do we in movement disorders do so much polypharmacy? Why is that?
Actually, when you ask that question, I can just hear Dr. Torres-Yaghi in the back of my mind from working with him so much. He always tells patients that we use rational polypharmacy. That's what he says. We're using rational polypharmacy, and it's true. So we use different methods and different ways to make your body think it has more dopamine than it does. And so we don't, it's not like blood pressure medication where we want to use one medication and sort of maximize the dose before moving on to something else. We like to use low doses of several different medications. So for example, something to recycle your body's natural dopamine, something to enhance the receptors for dopamine in the body, and sometimes giving you body extra dopamine. And we use all of these different methods to kind of get the body to think it has more dopamine than it does. And this method of using sort of rational polypharmacy prevents the motor fluctuations that can occur down the line if we just were to use one therapy and augment it very quickly.
Yeah, and we're learning that there are so many more chemicals than just dopamine that are deficient in Parkinson's. So not only do we need to sometimes stabilize dopamine, but we have to stabilize serotonin. We may need to stimulate GABA. We may need to inhibit glutamate or NMDA receptor blockade, et cetera. Now we have A2a inhibitors, another group of class of drugs. So it is multiple different medicines. Small amounts maybe sometimes give us the best quality of life for our patients. And again, this was discovered back in 1975. So if anybody's ever watched the movie Awakenings, they gave 1 to 2 grams of levodopa every single time they gave levodopa to get a symptomatic response to levodopa. If you gave 100 or 200 milligrams like we do today, there was no response when you use pure levodopa. But you put it together with carbidopa, you prevented all the side effects and you made it more effective. You made it 10-fold the efficacy to get more across that blood-brain barrier. So the term rational polypharmacy was born in 1975 when you put carbidopa and levodopa together. So that's why you'll see us as movement disorder doctors be able to give multiple drugs, trying to give the best response for our patients and the best quality of life and the most on time and reduction of off time. And that's when the medicines aren't working. I also have another question that did come in from one of our esteemed individuals watching tonight's presentation, and part of the Funda Fellow family, very near and dear to our heart. And he's asking about how quickly research has gone through COVID-19. So we have seen how quickly we can come up with a vaccine. 9 months is unprecedented. Could some of these type of protocols or some of these types of procedures that were used with the production of an important agent like the COVID vaccinations, could that be used for Parkinson's? And I think, yes, I think we have learned how quickly we can come through and come up with answers. And I think that's something that I think we as a community have to really go back to the FDA and say, hey, why does it have to take 10, 15, or 20 years to get something finally across the threshold to get FDA approval? Especially when you're seeing signs that there may be an efficacy, there has to be a better way. And I think that's really a challenge for us in medicine and in research, but also in government as well. A lot of barriers had to be broken down to be able to get that vaccine moved quickly. If everything would have been left in place, we would all still be wondering when the vaccine is going to be performed, but finally get across the FDA. And technically, we still don't have formal FDA approval. So these are issues that I think we as a society have to answer. And I think you bring up a great point. Could some of those same protocols be used in disorders like Alzheimer's and Parkinson's? My answer is yes, because we definitely are seeing a wave of an increase in these disorders. So the quicker we come out with true disease modifying therapies, the better for those patients, those families, and ultimately our society. So I think we've come to the time where, and I really want to thank Dr. Mundell. Thank you so much for spending your precious evening with us and our Funda Fellow family, and same with you, Dr. Torres-Yaghi. So thank you both for sharing your knowledge and your experience with myself and all our members of our Funda Fellow family. Now, what I would really like to do is to open the floor now to one of our current fellows, Dr. Emilia Carwin. Dr. Carwin is one of our senior fellows. You met earlier this year, Dr. Stephen Nakano. So to be fair and balanced, I want you to be able to show off a little bit Dr. Emilia Carwin, who's just done a tremendous job in her fellowship. We're very proud of her as well. And she'll be joining a private practice group in Denver, Colorado this summer. We're sad to lose her because she is a native from around here, but she's going to go to a new community who's in desperate need of a very well-trained movement disorder physician. So the floor is yours. Thank you so much, Emilia.
Thank you, Dr. Carwin. So as Dr. Carwin mentioned, I'm one of the Senior Movement Disorders Fellows. I know that I've met several of you over the past 2 years, and I just wanted to say thank you very much for coming and supporting the fellowship program in the way that you do. This really is a unique program. I did my residency actually at the Cleveland Clinic, and while I could have stayed there, Georgetown really kind of drew me in during the interview. That everyone off the bat was amazing. It was wonderful to meet Dr. Pagan and Dr. Yaghi and Dr. Mundell. And then additionally at that interview, I was able to meet with Dr. Musa as well, who is in charge of the translational research program. So So I talked to him quite a bit about the nilotinib studies, which were going on when I was interviewing, I guess at this point, 3 years ago now. So it was wonderful to just see his excitement and his passion for the research, and then to be able to combine that then with the clinical aspect of everything that I've been able to do as well at the program. It's been a really wonderful experience. I mean, Georgetown has this unique balance of being both at the forefront of the research, but also at the forefront of diagnostics and therapeutics. So I wanted to find a program where I actually could do both the research, but come out of the program as a strong movement disorder specialist, where I can know how to help my patients and approach the entire patient. You know, whether we've talked a lot tonight about the cognitive issues and the autonomic issues that come with everything. You know, I feel very comfortable being able to manage the whole patient instead of just looking at the motor aspect. And I think that is so important and something that is unfortunately lacking in a lot of the community. As Dr. Pagan mentioned, you know, with all of the work that's been going on, as much as he teaches us, we're very comfortable using all of the different medications that we have for Parkinson's and the Parkinsonism. I think we've got 30 something medications at this point. And when we go out into the community where I'm going, they've actually told me they are desperate for me to get out there because they just have everyone on a dopamine agonist and Cinemet. And so they really need the help. And I'm excited to be able to go out and start my practice out there. But I will miss this program very much. And Dr. Pagan and Dr. Yaghi and Dr. Mundell have all told me, you know, they're there for us in the future. My education does not stop with me leaving the program. So I just wanted again to say thank you for supporting such a wonderful and a unique program. And thank you to Dr. Pagan and Dr. Yaghi and Dr. Mundell as well.
Thank you. And thank you, everybody. This was a huge topic to discuss in an hour. You know, we're making plans to definitely be a little bit available more and do more education. I think education is also extremely important. The better informed, I think the better that our patients are ultimately going to get the best treatments available. Thank you again for all your support. God bless everybody. Stay safe.